a lot of what I do is screening. That's actually
Mhm.
my area. I do a lot of research in that area specifically. That's my focus because breast radiology does a lot. We treat, we do procedure, we
Mhm.
diagnose, but screening is a huge part of breast radiology because 40 million women a year get a screening mammogram. And I think it's a big ask to ask women, half of the population above the age of 40, to enter the healthcare system when they're healthy.
Okay, I'm excited. I'm here today with Dr. Hannah Milch, and I'm really grateful because I don't get to interview as many doctors, physicians, clinicians as I would like to because you guys are so busy, rightfully so. So I feel like I'm sneaking into your schedule. So I'm incredibly appreciative. So welcome to the SEAM podcast, Dr. Hannah Milch. We're going to talk today about diagnostics. We're going to talk about diagnostic radiology, what that means, about your field. I think it's fantastically interesting and also really important to women's healthcare in particular, obviously healthcare in general, but we're going to, I focus on sort of the women's space. So will you start by just giving a little background about yourself and how you ended up in this very specialized field?
Thank you so much for having me. So I am a breast specialized radiologist at UCLA. And after medical school, when I chose radiology as my specialty, it's a long fellowship residency. It's 5 years, and you kind of get a taste of all the different types of radiology. So you spend some time in neuroradiology and bone radiology and chest and abdomen and all the different disciplines. It's interesting. When I chose breast, it was kind of an aha moment for me when I was on my breast rotation in residency. It's a very special niche within radiology. In many ways, it's very much an art. So medicine is like a blend between an art and a science. And I really like the balance of that art science in breast radiology specifically. I joke with some of my colleagues and other radiology specialties, it's kind of like the polar opposite of neuroradiology, where you have to memorize like thousands of different parts of the brain and all the different anatomic structures. The breast is just the breast. It's very simple. You learn you could count on one hand, what makes up the breast tissue. But the interest and the joy and the rewardingness of discipline is really mastering the art of looking at the imaging, whether it's mammograms, MRIs, or ultrasounds. It's always the same body part. We do a lot of procedures. So we do biopsies and pre-surgical localizations and some other procedures. And importantly, most importantly, we are talking to our patients, whereas many other radiology disciplines are often removed from the patients primarily. So on a clinical day where I'm seeing patients all day with different questions, concerns, things they felt in their breasts. And then, of course, if we find something on the diagnostic workup, we then perform the biopsy and we have that, continuity with our patients. So breast radiology is a very special niche and it's very different than other radiology specialties. And people are always saying you either love it or it's not for you. It's very black or white.
You love the breasts or you don't.
Exactly. It's very interesting. And that's what we find because when we have residents and fellows, rotate with us, it just clicks like, oh my gosh, this is what I must do. Or
Yeah.
no, I'm going to go back to, neuro or bone or whatever. So, yeah.
So you said a bunch of things I want to just really dig into. The first one was about how there's only so many layers of breast radiology. So will you talk about those things, those layers, those pieces of it, and why they're important or what they mean?
Yes. So speaking anatomically, it's, what is actually in the breast. So radiologists, we look at imaging as a big part of our work. In terms of the layers, I meant literal physical layers. So
Yeah.
you have the skin and then you have the subcutaneous fat, which everyone has right under the skin. And then you have the breast tissue, which is combination of ducts and what's called fibroglandular structures. that have different anatomic pieces. And then that's basically it. You have some fibrous tissue that kind of brings everything together. You have more adipose tissue or fat interspersed. And that gets into the important topic of breast density, which has to do with how
Mhm.
much of the dense tissue you have versus the fat in the breast. And then you have blood vessels and lymph nodes. That's basically it. These are the things we dissect and decide, what's important, what's not important, which in my opinion is just as important as finding the important stuff, is being able to
Mhm.
reassure women when everything's fine. That's kind of what I meant by the layers. It's just the
Mhm.
very basic anatomy of the breast.
A lot of women talk about dense breasts.
Mhm.
And I have dense breasts. I do mammogram and ultrasound every year. Can you explain that a little more? Because I don't, and you just did by talking about the dense breast tissue, but will you give a little background to that, what it means, how one knows if they have dense breasts? If you're young, you've never had a mammogram, I mean, I've met women in their 30s, if you can imagine, highly educated in the workforce, women who've never seen a gynecologist, let
Mhm.
alone had a mammogram. How do you maybe know if you have dense breasts? It doesn't mean you have big boobs if you have dense
No.
breasts. So we just break that down like into the almost simplest terms so that
Yes. Yes.
someone who has no idea what you're talking about, really understands what it means and what the implications are.
Yeah, absolutely. It's really important. First of all, dense breast tissue is very common. Half of all women who get a mammogram have dense breasts. So it's not like, oh my gosh, I'm one of those few that has dense breasts. It's
Mhm.
extremely common. And it doesn't mean there's anything wrong. What it means is that the ratio of fibroglandular breast tissue, so the glands, the ducts, the fibrous bands, and ligaments relative to the fat is higher.
Mhm.
So, what that means for a radiologist is that when we look at your mammogram, x ray type imaging is all black, white, and shades of gray. Fat is darker. It's kind of, black or dark gray. And the breast tissue is whiter. So if you have dense breasts, then that means your mammogram's just going to be whiter. And if you're not dense, your mammogram picture is going to be darker.
Mhm.
The reason that that matters is because cancers are whiter. So if you have dense breasts, then you're looking for something that's whiter, a whitish shade in a field of other
White.
white shades.
Okay.
It masks findings.
Mm.
Whereas if you have a darker appearance, because the way the X-ray beam goes through fatty tissue is it's able to go through it much more quickly, then anything white in that breast is going to show up more easily. So it is harder to find breast cancers on your mammogram if you have dense breasts.
And so then the recommendation is to have ultrasound along with a mammogram, from what I understand. So can you dig into that and then what ultrasound
Sure.
shows and how it shows it?
Yes. So two things. First of all, not only is it slightly harder to see cancers in dense breast tissue, but women with dense breasts have a slightly higher risk of breast cancer as well. So those are
Okay.
actually two distinct phenomena. They're related, but they're different. So one is just it's harder to see it. The other is your just lifetime risk or your 5-year risk of developing a cancer is also higher.
Why? Will you just take a step back and tell us why?
You can hypothesize why it grows out of cells that are tissue based, not
Mhm.
fat based. So if you have
Mhm.
more tissue, that's like one way to think about it. You may be more inclined to create those atypical cells. It's not fully understood. There are just a lot of, observational studies that demonstrate greater breast cancer prevalence among women with dense breasts compared to women without dense breasts. So you mentioned supplemental screening with ultrasound. So the first
Mhm.
most important thing to point out is mammography is the only breast cancer screening tool we have that has evidence to show that it saves lives from breast cancer. We don't have evidence for that for MRI, and we don't have evidence for that for ultrasound. So all women, regardless of your breast density, when you are reach the appropriate age, we recommend screening mammography first and foremost. That's the first thing. So then we refer to things as supplemental. The reason they're supplemental is because they're in addition to mammography, not instead of mammography. Those options include ultrasound or MRI. The majority of women like you, Amy, will get an ultrasound in addition, because an ultrasound can pick up a few cancers that could not be seen on a dense breast in a mammogram. So not everybody with dense breasts gets supplemental ultrasound. It's actually considered a choice for women to consider. There are pros and cons to that decision. So the pros are you may find an early cancer that the mammogram missed. That's the critical pro. But evidence suggests it's very marginal, just to be clear. It's maybe 2 or 3 more cancers per 1,000 women. It is unclear if detecting those on ultrasound impacts long-term outcomes more. So it actually is a little bit controversial in our field whether women with dense breasts should universally be getting ultrasound to begin with. MRI, on the other hand, is much more sensitive. So it can detect, maybe double as many as mammography. So more cancers per 1,000 women than ultrasound. It is recommended if you have dense breasts and you also reach a certain risk threshold, or if you have not dense breasts and you hit a certain risk threshold. So if you have greater than 20% lifetime risk of breast cancer. And honestly, one of the things that I do love about breast radiology and breast cancer care, it's a very dynamic, evolving process with a lot of research going into it. Because an important next question is, well, why shouldn't all women with dense breasts get MRIs? And it's extremely valid. And the technology is continually evolving and the recommendations are evolving based on the most up-to-date evidence. But right now, if you look at the risk benefit of false positives and all the unnecessary downstream costs of too much imaging, it's only recommended for high-risk women to get the MRI. And ultrasound is a choice. Some women with dense breasts get it and some don't.
Okay, I have 2 questions out of that. The first is, I know the answers, but I'd like for you to say them because it's always different when you hear them from a doctor. What are those risk factors that are indicators?
So basically, we have a number of risk models in breast, and usually you're wherever you get your mammogram, and or you can talk to your primary care doctor and they can refer you to someone, or they can do a risk calculator that calculates your lifetime risk. Those risk models are made up of a number of factors, some of which include age, menopausal status, family history, of course, history of taking hormone replacement therapy, history of having a biopsy that yielded a high-risk lesion. So if you don't necessarily have a history of cancer, but you have a history of needing surgery for something with atypia, I believe BMI goes into most risk models and some other environmental factors. It's kind of a laundry list of items that go into these risk models and help you predict your lifetime risk of breast cancer.
I thought that HRT, hormone replacement therapy, does not increase your risk for breast cancer. Like it's a debunked study.
It has been somewhat debunked.
I'm forcing you to really get into it
It's a
here.
complicated topic, and I don't want to say anything incorrect. It's a complicated topic. I believe it is still included in a number of the risk models, though.
Yeah. Based on an old study. Got it. And then also, I would assume genetic mutations if you'd been tested.
Correct.
For that.
Absolutely.
Okay.
Yes, exactly.
Yeah. So the other thing I wanted to ask is, so in your recommendation, having seen, because you see patients and you also look at imagery and make suggestions, what do you recommend for women? An ultrasound is easier to get than an MRI, for sure, for lots of different reasons, cost, access. So what do you recommend for a woman who has moderate risk? Maybe he doesn't hit the 20% sort of threshold, but definitely has a moderate risk, dense breasts. It's interesting because, and I ask that for lots of reasons. I think it's a question a lot of women would like to ask or don't even know to ask, but would like to know the answer. And also we have, and you're a testament, you still have a job. So we are, so a lot of us have this sort of false impression that breast cancer is a thing of the past. And no one gets breast cancer. And if you do, you're going to be fine. And it's certainly more true than it was, but that's not true, which is why you have a job and many others like you do. We still know people who die of breast cancer. So what do you recommend? And I know you're not the end all be all, but you're in the mix. So what do you say?
Well, this comes up a lot because, I talk to women every day. We don't talk to every woman who gets a screening mammogram, but anytime you come in from a symptom, usually a doctor will come talk to you and give you the results. And I get a lot of questions about, well, should I be getting an ultrasound? Should I not? Should I be getting an MRI? How frequently should I be getting a mammogram? You will not find one source with one answer. That in and of itself is so
Mhm.
frustrating for women.
100%. And I think knowing that and saying that by someone in the field in itself is very important.
Mhm.
And I think that leads to, in my opinion, listening to people who you trust for whatever reasons. For me, it's my gut, it's my connection. So I think that's an incredibly important fact that you just said. That
Yeah. Yes. No, thank you. I agree. I think that it's almost kind of period, end of sentence. I mean, there are caveats where the recommendations by the main societies are getting mammography. Some say annually, some say every other year. And supplemental ultrasound is a discussion with your doctor. I don't believe this could change in a year or 6 months. I don't believe any recommendations are outright get an ultrasound if you have dense breasts. I think it is always what we refer to right now as shared decision making, which is essentially you talk to usually your primary care doctor, but you can also see a risk specialist or a genetic counselor, if you're getting tested for potential family history, and you come up with what makes the most sense for you.
Mhm.
I will tell you, this is a very controversial area. There are some areas, some programs that will not do screening breast ultrasounds. They will not do them because they generate too many false positives for an extremely low additional cancer yield. So that's one end of the spectrum. We don't even want to do them because we don't think the evidence supports their use. The flip side of that is you have a lot of women who have dense breasts, may have a slight increased risk, but not enough to warrant annual MRIs. And you can't see much on their mammogram, and they want another test to reassure them that they're okay. And ultrasound can be useful in those situations. So it really is a personal decision. And there's not an answer yet, but maybe there will be in the future. I think that some women, it really does make a lot of sense to get that ultrasound, but it's not for everyone.
So I do a lot of work with women who are potentially at increased risk for breast or ovarian cancer. So
Hmm.
obviously there's a lot more screening available that we've talked about already for breast cancer than ovarian cancer, which is pretty much essentially none or nothing, as definitive that you just walk in and do in a center every year or whatever. Everyone wants assurances. And I think so many women, including myself, we go for our annual mammogram. For me, it's ultrasound as well. And I understand, and I know everything that you're saying. And it's a lot about, well, I'm just doing it.
Yeah.
But it's still not a fail safe. What are the other things that we can do to, as I always like to say, at least know you're doing everything,
Yeah.
knowing that shit happens. But what are the other things that we can do, knowing that even a mammogram coupled with an ultrasound, that's not like a definitive check mark. You are cancer free, woman.
Yeah.
Go on. We'll see you soon. So what do you say to that?
I'm very careful in how I answer a question like that. Let me tell you
Hmm.
why. A lot of what I do is screening. That's actually
Hmm.
my area. I do a lot of research in that area specifically. That's my focus because breast radiology does a lot. We treat, we do procedure, we
Hmm.
diagnose, but screening is a huge part of breast radiology because 40 million women a year get a screening mammogram, and it's just a huge part of what we do. I think it's a big ask to ask women, half of the population above the age of 40, to enter the healthcare system when they're healthy.
Oh, it's the heart.
Yeah.
I mean,
It's brutal.
yes.
It's
That's what
brutal.
I do. I see healthy women who are at increased risk. I mean, it is nearly impossible.
They're,
It's
they're living their life, right?
Mhm.
And we as a healthcare system is saying, come to us, get all
Mhm.
these tests. We're doing it with good purpose because we have data suggests we can save lives from breast cancer by doing this. But we are drawing people into the healthcare system who are just going about their lives feeling fine. And we're saying, come do this, and then add all the worry and the additional tests and the biopsies and the surgeries. Even when you don't have breast cancer, sometimes you have to get a surgery.
Yeah.
So the reason I'm hesitant to give women more to do is because I think that we should just be living our lives as best we can and not getting sucked in with, I must do this, I must do that, because unless there's really good evidence to support it. So like, some women are like, oh, if I stop eating sugar, I'll decrease my chances. The data on that is not robust. So, I just don't like to, I think you live your life, you try to live a healthy lifestyle, and you try to stay on top of the appropriate evidence-based screening recommendations and try to live your life. I really don't like to give people too much to do.
Yeah, I hear that. I do. And I think of the women, especially women over 40. And if you're just talking about in the United States, it's an enormously diverse group. So, from socioeconomic to where we live, women in the middle of nowhere in really rural areas with, long drives to even go see a primary care physician, let alone a mammogram, to get a mammogram somewhere, is different than women who live in cities, and it's easy accessible, education level, all the things. And I think about that and talk about it a lot. I agree with you. I think there's only so much you can do. And some women, want to know everything and want to do everything. Others are the total end of the spectrum, right?
Right.
And are like not even on their radar, like they're not even thinking about it. And then everything in between. But I do think that there's something important and impactful and empowering about knowing the options
Yes.
and also being educated that what those options yield, not just are, but like what it means. Like, that a mammogram isn't definitive. Mammogram plus ultrasound isn't definitive. That MRI, all those things. And it's unusual for a doctor to tell you that.
Yeah.
It is. It's more typical that your doctor will say, okay, here you are. This is where you are in your life. This is what you need to do. And then we'll keep you on track. I think that is the much more norm sort of declarative statement that we get from our doctors who are, and I'm not knocking them. I'm fabulous doctors. I've heard that from mine who I pick and choose really carefully. And I wonder why that is. Is it they want to sort of take the worry off of you, or they believe it, or it just is what it is. And as you say, it's an evolving field.
It is an evolving field. I mean, I will tell you that there used to be recommendations for women to perform self-breast exams.
I talk about this a
And-
lot.
yeah. And that's my understanding is the current guidance is to be familiar with your breast tissue so that a change you're more likely to detect, but
Mhm,
not putting the onus on women to do like a full
mhm,
breast
mhm,
exam. If you see your primary care doctor regularly, usually a breast exam is part of that, physical exam. And, we do get a number of women referred where the primary care doctor felt something. And
mhm,
good news, it's usually nothing for women out there. If that happens to you, because I've had, gotten calls from friends when they're, panicking that their doctor felt something, and I try to get them in right away. And fortunately, the vast majority, it's a benign cyst or a patch of dense breast tissue or a benign fibroadenoma. So usually it's not cancer, but
mhm.
we're trying to detect the rare times that it is. So there are things that you can do. I guess there's so much you can't do. And I know that's not something you want to hear. You can do
No, I get it.
everything. You can do everything right. Most of the women I see with breast cancer did everything right, So
Yeah.
that's what's hard to say, do this, do that, I think.
I agree. And I think that's kind of always been something I try to hone in on. It's like, things happen. There's just things change in your body, cancer cells form. There's often nothing you can or should have done differently to have made or not make that happen.
Mhm.
Um, but there is power in taking control of what you can do and taking control of the knowledge that you have, and then deciding yourself how to sort of use that into trying to stay healthy. Like, you can say, I don't care. I'm gonna stick my head under the sink. I'm burying my head and I'm going through life and I'm gonna drink and eat and party and do it. And not, I don't see doctors. I don't believe in preventive care. Fine. But if you make that choice, like actively, then
Mm.
good for you.
Yeah, that's a choice. That's a very active choice, and
That's
which
an
is not
active
what I'm
choice. And
promoting, by the way.
yeah, no, neither am I. But I'll tell you, I know women like that. They're like, it is what it is. And I was talking with my husband the other day. Actually, we were walking, and I said something like, it's just an interesting situation because the way I think about my own long term life, where my mom died at 53. She was diagnosed with ovarian cancer at 48, and she died at 53. But my two grandmas lived to almost 100, on each side. And so it's like this weird moment of like,
Mhm.
whose genes did I get? Where's it going to like land for me? And so I know that I could do all the right things. I also know that, things happen. And
Yeah.
the best thing you can do, I spoke to a very good friend of mine from college. I interviewed her a few weeks ago, and she had tons of breast cancer in her family. And it was inevitable pretty much that she was going to
Mhm.
get breast cancer, which she did at 48. And we were talking, she's like, but I knew where to go. Like I knew what to do. I knew to do all the right things and know that this could happen anyways. She said, but what I think what I got from her was what made it like kind of okay was that she knew how to hit the ground running if that
Yes.
diagnosis came in. There's no easy path in that situation, but there is something I think really important for us all to know about your field because there are tools, there are diagnostic tools, there are clinical tools. And then I think the most sort of beautiful thing that you've said a few times is that this is changing all the time, and we can look back a few decades and we have tools now that we didn't have.
Mhm.
So, on that, what is in the pipeline or what would you love to be in the pipeline in your specific niche of a field of breast radiology?
Well, I have to mention that I am part clinical, part research. About at least over half of my time is in breast cancer screening research.
Which is my favorite kind of doctor ever.
And my niche, my research niche is how to leverage artificial intelligence
Mm.
tools to improve breast cancer screening. So there are a number of tools. I hope that one day there's a blood test that helps triage women at highest risk. And I think there will be. So I think there's a lot of exciting things. It's extremely, extremely dynamic field. But I should probably speak about what I know most about, which is that I think that, in 5, 10 years, AI will have a very, very prominent role in breast cancer screening. And my work is to study that translation from showing that the algorithm works in a testing lab setting
Mhm.
and proving that it also will work in real world practice. So it's that translational step of clinical implementation because historically, new technologies that are very flashy and exciting in an experimental setting don't always prove to be valuable to women when they're actually getting screened for breast cancer. So we have examples of that with older computer tools. So we're trying to make sure that with AI, we're very careful in how we integrate it and make sure that it's helping without causing any unintended harms. So that is where my research is, and I'm very cautiously optimistic that in not too long a time it will have a valuable role to play in breast cancer screening.
That's amazing. One of the things when my husband's partner says, I'm going to fudge it, but it's okay because he's not listening to this. But they are very deep in using AI and adapting it into their business. And he says, you wouldn't have even known 4 months ago, let alone 4 days ago, and in some cases 4 hours ago, the tools that are coming on board and figuring out how to understand them and then how to implement them just to enhance the work you're doing,
Mhm.
and to give you new abilities that you couldn't have had 4 hours ago, 4 days ago, 4 months ago. And that, some people are really scared by that. I think it's
Mhm.
incredibly exciting. And kind of if you don't adopt it, then, you're not doing everything you can and taking advantage of, these sort of incredible technological advances. As I think we were talking about the other day, it was like the difference between living in the dark and, living in black and white, living in color. It's like that Wizard of Oz moment, which, might not be that dramatic, but But I think it's really exciting. And I love that you mentioned that, and also that that is your field of research. And, if there's one thing people ask me all the time, unfortunately, who have been hit by cancer or cancer in their family, they, it looks to me like, who should we see? I live here. Who's the right person? My answer is always someone who's doing the
Mm,
research, who's seeing patients and also doing the research. It's a completely, in my opinion, in my experience, a completely different mindset, a completely different way of looking at what's in front of you, and just a game changer when it comes to care. So I think what you're doing is obviously incredible and really important. And it seems like sometimes we've made it as far as we can in this world of breast cancer diagnostics and breast cancer research. But the truth is, we're not even
there's
close.
so much. And it's
Yeah.
such a good point because there has been so much progress. There are, of course, horrible stories. Obviously,
Hmm.
your mother, and we still see that, and it's terrible. And there also has been so much progress and the treatment, it's not just from the imaging side. The
Right.
treatment, right, of course, has gotten exponentially better. So, coming at it from multiple angles and being able to see in the clinic how it's affecting patients and then study it. I think, as you say, that's what I love about it because I can use what I see, doing my clinical work to drive the research questions. So I do think that the progress that's been made is incredible and that there's a lot more ahead of us for sure.
It's amazing. Well, thank you so much. This was awesome. This was such a great conversation, and I'm really glad I got to meet you. But I think that, we're also grateful and thankful for the work that you do, and that you chose this as your specialty, and that you, I think, had the wisdom to see that this is the more artsy side of science. Because I think looking at it that way dramatically changes lives. And I think it's, from the sidelines, like, really beautiful to watch. So thank you for seeing this your world through that lens. I think it'll change a lot of women's lives.
Thank you, Amy. And right back at you because I've heard the immense work that you do and how impactful it is. So just as critical to move this forward and help women, as many women as
Yeah.
possible. Thank you so much for
Yeah.
having me.